Hi, I'm Dr. Polly Watson, your host. Today, we're going to just dive right into the controversy and start off by talking about a really common situation I see in my practice where women come in and say, my doctor won't check my hormones. And that's one of the reasons why they're coming to me, is because they are frustrated and they feel unheard. And so hormone assessment can be complicated and a little tricky. So we're just going to dive right in and talk about some of these complexities. So maybe you can understand why some healthcare providers are really reticent to do that. What are the limitations of this testing? And also really take some space about why the testing can be helpful in some situations. So many women come in again just with fatigue, weight gain, brain fog, sleep disruption. They just don't feel like themselves. And they've asked their doctor for testing, maybe even also asked their gynecologist for testing, and they won't order it. And oftentimes women leave these healthcare interactions feeling dismissed and unheard. And I feel like that feeling of dismissal is amplified if during the same appointment, they're offered an antidepressant or a birth control pill. So the patient is coming in at this issue with curiosity, wanting to understand her body. And not only is she sort of being denied the opportunity to investigate, but what she's offered is just, here, let's go mask your symptoms. And that's not really what she came in wanting. She came in with curiosity. So a lot of times when these women come into my office, they're pretty frustrated and sometimes a little angry. So let's just pause for a moment and kind of think about what has led up to this kind of moment in this woman's health trajectory. If we reflect on the messages women are getting over the course of their reproductive lives, many of us have been told that it's normal to feel lousy. When we were moms in our 30s, we were told that, you're just tired and strung out because you're a new mom. And then when we hit our 40s, we're told, you're gonna feel tired. You're 40 now. You're simply getting older. This is just part of aging. And now that we're perimenopausal or in early menopause, a lot of our symptoms are just chalked up to that. And so it is appalling to me that the message many women are getting from the healthcare system is that we only are going to feel good prior to having children. And then after that is just downhill. And that's not acceptable. So I don't know about you, but I'm 50 and I have a lot more great years ahead of me. And I'm not willing to just feel like I'm going to feel exhausted and fat and tired for the rest of my life. I also know that I take so much better care of myself now than when I was 30, right? So when I was 30, I just finished OBGYN residency. I had been on call every third night, working a 33-hour shift for 4 years. I drank a lot of Diet Coke and I ate lean cuisines that had been microwaved in plastic. So I wasn't doing so great by myself. Now I eat a nutrient-dense diet. I sleep better. I lift weights. I do yoga. I know how to set boundaries and say no to things that don't serve me. So I refuse to accept that I'm simply in decline just because I'm getting older. I'm only at midlife. I'm not at the end of my life. So in my view, midlife is this perfect moment when we know who we are and what we want and are better positioned to go after it than we were 20 years ago. So let's go back and revisit this question of hormone testing through the lens of health promotion and empowerment. So here you are, your healthcare provider won't check your hormones. Why is that? Well, the healthcare provider, and I know I was taught this in OBGYN training, that hormone levels are constantly in flux. And so it's really hard to get a clear meaning from drawing them. And the other thing that is absolutely a possibility is that the healthcare provider may have had very little training in how to interpret the results. So they don't want to do the test because they don't know what to do with the results. So it's true that hormones change throughout the cycle, throughout the lifespan. But we measure a lot of things in medicine that change also. We just have to understand the context in which we're measuring the thing we're looking at. So, two easy examples are blood pressure and blood sugar. If you check my blood pressure after I've done a HIIT workout, had a double espresso, and then had a fight with my husband, my blood pressure is probably going to be high, even though I don't have high blood pressure. We know that blood pressure is dynamic with stress, caffeine, tobacco, exercise. That's why we're supposed to measure blood pressure away from caffeine, tobacco, when we're resting, when we're calm. Maybe you've come into a doctor's appointment and you were rushing to get there and you were anxious and you've never seen this person before. And the first check was pretty high. And they said, you know what? Let's let you sit down. Let's let you rest. Let's let you calm down. We'll check in again at the end of the appointment and it's come right on down, right? So we need to have some context about this blood pressure measurement, just like we would about when we choose to check hormones, where you are in your cycle, what are we measuring? Same kind of thing with blood sugar. We're often measuring blood sugar either fasting or after a specific glucose load. Maybe when you were pregnant, you remember getting that glucola test where you had to drink this really gross sugary drink and then get your blood sugar measured after that. We can also get like a hemoglobin A1C, which is a 3-month average of blood sugar. So a random blood sugar, if we don't have any context about when this blood sugar is being drawn, if someone got their blood sugar checked right after they ate an apple pie at Thanksgiving, they may look diabetic, but they're not actually diabetic because it wasn't a fasting blood sugar. So we have to interpret lab results or healthcare measurements in the context of what's happening when the lab or the measurement was collected. And I think hormones are no different. So if we go back to hormone testing, where does that leave us? We understand that hormones change, and we need to understand when in a cycle or when in the lifespan we're measuring them. Can we get any useful information from them? And I would argue that a conditional yes, right? So we need to know when in the cycle we're measuring hormones, and we may need to get more than one measurement. So we may not be making decisions off of a single measurement. We may be making decisions off of a trend. I think it's also really important that if someone wants to test your hormones while you're on oral birth control or a hormone implant, those values are not helpful. So sometimes women will come in and they bring me all these labs and they're testing their hormones while they're taking hormones. That doesn't tell me anything about what's happening to her body. It's just measuring that she's already on hormones. So it doesn't really provide any insight about what your hormones would be doing if you were in a natural state and you weren't having hormonal administration. So what are hormones that we can check and what can they tell us? So I usually focus on FSH, estradiol, progesterone, and testosterone in my perimenopausal, menopausal folks. I do want to insert something here and say that sometimes women who are well into menopause transition will come in and want me to check their hormones. And I'm not sure that that's a super helpful or useful thing to do. So if someone is postmenopausal for 5 or 10 or 15 years and they're having hot flashes and night sweats, I already know they don't have enough estrogen on board. If their estrogen level is 5 or 10, it doesn't really matter. If they want me to check in and see that it changes with hormone replacement therapy, I can do that to make them happy, but I don't get a whole lot of information out of doing that. Clinically, I already know where they're at. we're often thinking about doing hormone testing in that perimenopausal time, which can last for 2 to 8 years and can be a really confusing time to figure out, hey, are these symptoms coming from hormones or is something else going on? Okay, so many women are looking at hormones to sort of figure out where are they in this menopausal transition. And many of us learned about hormone testing, perhaps if we had a harder time getting pregnant, if that was part of our history. We might remember this hormone called follicle stimulating hormone, or FSH. And oftentimes, if we were trying to get pregnant, that would be measured on day 3 of the menstrual cycle. And it was an indication of kind of how well our ovaries were working. So FSH goes up as our ovaries are making less hormones. And FSH can fluctuate. If we were going to diagnose early menopause, so typically that's women who've stopped having their period before the age of 40, then we need 2 values taken at least 2 months apart before that diagnosis can be made. So again, we don't want to hang our hats on one hormone check. Okay. I think you're looking for clinical history, you're looking for patterns in hormone measurement. So I learned this kind of the hard way with a patient much earlier in my career. The person was in their late 30s. They were interested in getting pregnant. We got an FSH. They were starting to have some menstrual irregularity, and her FSH came back at 113. Okay, usually an FSH over 26, you're starting to think about a menopausal range. So 113 was like out of the ballpark. I thought there was no way she would ever get pregnant with that result. She proved me wrong. She later went on to get pregnant and have a healthy baby. So you can see why hanging your hat on one lab result can be really misleading. And we probably need to do, and so there's understandably a lot of healthcare providers don't want to fall into that trap. They'd rather just not look. Okay. So hormones change. A single measurement can be misleading. And I think that's also really important to understand now with the advent of these home kits that you can purchase over the counter and measure FSH. I don't think one test tells you a whole lot. However, I do like to partner with my patients. I want them to feel heard. I think that this is a really challenging moment in the life cycle as we're in perimenopausal transition. I think it's a really hard time to be on the planet right now. It's hard to have discernment about what's going on. So it may make sense to get several values in context of when it was done in the cycle, and also looking at a more comprehensive lab panel to rule out thyroid disease, to rule out prediabetes or anemia or vitamin or nutritional deficiencies. So we're not just relying on this one isolated lab value. We're taking a comprehensive history, we're getting other labs, and we may be looking at series of results over time. Many of us in perimenopause kind of feel like we're stuck in PMS. Our fuse can feel really short. Again, the world is also feeling really polarized and triggered. And so sometimes it's hard to figure out if this is hormonal or if it's just being a modern human. So hormone testing can bring a little bit of clarity if it's done correctly within some context. So we're all born having all the eggs we're ever going to get, and the quality of those eggs goes down over time. So when we ovulate, when we release an egg, we make something called the corpus luteum, and that makes progesterone, and progesterone is grounding. Progesterone helps our brains make a neurotransmitter called GABA, and that's an inhibitory neurotransmitter. So I think about GABA as Yoda, okay? So GABA is your filter. GABA is grounding. GABA is giving you that precious 10 seconds before you lash out at the end of a hard day and let you respond rather than to react. GABA helps us feel calm. It helps with anxiety. It helps with sleep. So in PMS, progesterone is low and GABA is low. We feel reactive, short-tempered, irritable. In perimenopause, as we're aging and our ovaries, our egg quality is going down, when we ovulate, we may not make as much progesterone, and that mimics this estrogen dominant, low progesterone, low GABA state, and we feel like we're stuck in PMS. So if a woman comes into my office and she's 46 and she's having a lot of mood symptoms, even if she's not starting with hot flashes and night sweats, it may make sense to check a day 21 progesterone to kind of investigate if her mood symptoms may be due to low progesterone. Maybe she's also having sleep disruption. Maybe her periods got heavier. Maybe her cycle length got shorter. All of those things are kind of letting me think about she might be low in progesterone. And we might measure this several times, right? So measuring hormones are a static measurement of a dynamic process. This is changing all the time, but we're not getting a random progesterone. If she's still cycling, we're going to get it during her luteal phase when she's built up enough progesterone around day 19 to 21 of her cycle. Okay. And if it's chronically low and her symptoms are also echoing low progesterone, then we have the opportunity to supplement with some bioidentical micronized progesterone in the second half of her cycle. And this can be a game changer for a lot of women. So rather than just saying hormones change, we don't check them, this is an opportunity to give some bandwidth back in a woman's life. This is an opportunity to perhaps help her sleep. This is an opportunity to give her a little bit of grace, a little bit of cushion, if you will, if she's feeling irritable, and maybe she also has kids and teens who are also feeling irritable. So in my mind, not checking the progesterone or addressing the progesterone deficiency is really a missed opportunity to offer a relatively simple solution that can make a huge impact in this transition period. What about estrogen? We're learning more and more about estrogen and the brain. There was a paper that reported that estrogen may be protective against neurocognitive decline if it started before the final menstrual period. So Menopause Society has come out and said that we don't have enough data at this point to say that the only reason to take estrogen is for neuroprotection and prevention of dementia. We're not there yet. I think by the time we figure this out, I'm going to be drooling in a cup at a nursing home. So, but I think there is some work that is suggesting that estrogen can be protective of the brain. Pauline Mackey is a researcher at the University of Chicago, and she published work years ago that found that when estrogen levels are fluctuating in perimenopause, it affects working memory and word recall. So in a premenopausal woman who has normal cognitive function, let's say you give her 5 things to remember and she has 20 minutes to take a break, and then she's got to tell you those 5 things again. She does pretty well on that score. The same woman goes through perimenopause. Her estrogen levels are all over the place. Her word recall goes down. And then Dr. Mackey demonstrated that when you replaced estrogen in that same population, you could restore her word recall score. So that's kind of cool. And certainly I've seen in my own life and my clinical practice, a lot of women will say their brain got back online when they got started on hormone replacement therapy. So This is a challenging time in our history. It's a challenging time in the life cycle, right? So many midlife women may be pulled in 1,000 directions with their jobs, with launching kids, with caring for aging parents. And it can be really hard to ascertain if this is just the world right now and their life, or do they have adult ADD, or are they simply distracted by social media and instant messaging, and we've sort of cultivated distraction. So we have many of us have parents with dementia, and here we are feeling like our brains are all over the place and we can't concentrate, and we get really concerned and anxious that maybe we too are starting to have some neurocognitive changes. So again, we're in this moment of uncertainty. There's so many things that could be affecting our focus and our brain. How valuable would it be to check someone's estrogen, and if it's low, replace it, with the understanding that they're in perimenopause and they may not need that. They may be in a lull and they may go back up, and you may have to readjust, right? But a few years ago, I was really struggling with word finding, and I got my estrogen levels checked. So I'm 50, I'm perimenopausal, and I was already on progesterone at that time. I wasn't having hot flashes and night sweats. My main complaint was fatigue and focus. When I got my estrogen level checked, it was 20. So to put that number into context, the SWAN study looked at estrogen levels in a small subset of that study, and they found that an estrogen level of 44 was when most women's hot flashes and night sweats went away. So my estrogen level was half of that. So that was definitely low. And I got on a bioidentical estradiol patch, and within a few days, I felt like my brain was back online. It was so comforting to find something that I could easily fix. It was also really helpful because I do have dementia in my family, and that was a concern that, how am I going to be able to do my job if my word recall is going down? So I appreciate that hormone levels change, and we need to look at them in context of symptoms and more comprehensive labs. We may need to get a series of these, and we need to inform particularly our perimenopausal patients, that their levels can change. So 1 month in perimenopause, you could be too low. The next month, you could be too high. It requires a partnership. But if we're willing to engage in that complexity, and we're willing to give the patient some more information, I think we can potentially spare a lot of perimenopausal women years of struggle. We don't have to wait until they're completely postmenopausal to start hormones. Another hormone we might check is testosterone, and that is its whole own podcast. So, but just to briefly kind of go over this, we will often check a total and free testosterone, as well as sex hormone binding globulin, which is the protein that binds up testosterone, particularly in women that are complaining of fatigue and low libido. So, in my experience clinically, what's behind this, I want the doctor to check my hormones, is oftentimes the question behind that is, when are these symptoms going to be over? And many of us can endure challenging things if we know what to expect. If you tell me I'm just going to have to go running, that's going to be really hard for me. But if you say, Polly, you're going to have to run 2 miles, and then you can walk for half a mile, and then you have to run for another 2 miles, I can do that. I need to know when it's going to be over, so to speak. So unfortunately, hormone testing can't tell me when your period is going to stop, or if you're having hot flashes and night sweats and symptoms from menopause, when the symptoms are going to stop. And so I think that's a really important thing to clarify for people. What exactly are we going to get from this information? We're not going to be able to, it doesn't serve as a crystal ball. We're not going to be able to tell you when it stops. or when your period will stop. We do know from the SWAN study that menopause experience varies widely. On average, women experienced hot flashes and night sweats for about 7.5 years, with about 4.5 years of that after the last menstrual period. We also know that there's some racial diversity among symptoms experience. So African American women have the longest duration of symptoms and usually the worst severity of symptoms, and Asian women have the shortest duration of symptoms. We also know that this perimenopausal window, this time when our hormones are changing, but we haven't stopped having a period yet, kind of the second puberty, if you will, that period of time can last 2 to 8 years. So you can imagine why women are coming to their doctors saying, hey, where am I and when is this going to be over? Because it's such a long time to experience symptoms and not know an endpoint. The other thing, well, we learned a lot from the SWAN study, but one other thing we learned from the SWAN study is around 13% of women aren't going to stop having hot flashes and night sweats. They're going to have them through the end of their lives. And so, again, I think we need to embrace the diversity of experiences here, because a lot of women are left in the dark when their healthcare provider says, okay, we only give hormones until 60 and you should be done by now, right? Just sort of like that doctor telling my mom, hey, you're 39, you're 38, you should not be having menopause, right? Some women are going to have menopausal symptoms for the rest of their lives. So again, if values of hormones are unpredictable, what is the value in checking them? I would say identifying low progesterone in perimenopause and treating it can restore sleep and help moderate heavy or erratic cycles. I think another important point is that a lot of the conversation around menopause and perimenopause and defining early or late perimenopause was really focused on women who had a normal menstrual cycle. And there are plenty of women, particularly with women who have PCOS, which is anywhere between 5 to 20% of the population. They didn't have regular menstrual cycles in their reproductive years. And so they may be coming into perimenopause without that symptom to sort of let them know what's going on. Checking hormone levels and getting trends of lower hormones may allow you to start hormone replacement therapy before the final menstrual period and potentially protect your brain. Again, we're still learning about that. Definitely will protect your bones. We know that bone loss starts at a very accelerated rate in the perimenopausal period. I would also add that hormone replacement therapy can be especially protective of mood during this window. And then there are plenty of women who have ovaries who don't have periods to guide them where they are in the process. So if you have a hormonal IUD and maybe you're not having periods, or maybe you've had an ablation or you've had a hysterectomy, you have no way of knowing if your symptoms are due to sex hormone change or to other factors. So again, if you're in that situation and you're not having a period to get, let's say, a day 21 progesterone, what could you do to try to figure out what your ovaries were doing, if they were doing anything? You could get an LH predictor kit. Again, if you were trying to get pregnant, you would use an LH predictor kit to measure ovulation. And then you would check a progesterone measurement 5 days after the LH surge occurs. This may require a little bit of patience. If you're in perimenopause, you may not be ovulating every month. And so you may have to do this for several months before you catch an ovulation. But that's still helpful information. So to summarize, hormone testing can be unpredictable. It may be helpful to get several measurements in conjunction with comprehensive labs and clinical symptoms to make an assessment. I would say that hormone testing can be insightful in women who don't have regular periods due to an IUD, an ablation, or a hysterectomy. We don't have a test that will predict when menopause will occur or when symptoms are going to start or stop. If you'd like more information, I've put together a basic list of labs that I think can be helpful. Click on the link below to access this resource. And thanks so much for listening. Thanks for listening to Menopause Rescue. If you enjoyed this topic and want to learn more, check out our resource guide for this episode.